Good morning, everyone. So today's topic for the PGCR is adolescent to young adults building a strong foundation. I would like to thank you, Dr. Jaya Chaudhary ma'am, Dr. Rupesh Masansa for being the chairpersons. Today we want to talk about something that's often overlooked in our medical setting, that is adolescent health. Adolescents are not just older children or immature adults, they are distinct population and face unique health challenges that require specific attention and understanding. So who are adolescents? Adolescent word is derived from the Latin word adolescere, meaning growing into maturity. It is a period of transition between childhood and adulthood and is a time of rapid physical, cognitive, social and emotional maturing. WHO defines adolescence between ages 10 to 19 years, and according to Government of India, it is between 13 to 19 years. Youth refers to ages 15 to 24 years. Adolescence is again divided into early, middle and late, that is 10 to 13, 14 to 16 and 17 to 19 respectively. Adolescents constitute 1.3 billion of the global population, that is total 16% population of the world. India has the largest adolescent population in the world, that is about 253 million, approximately 18% of the total population. Why it matters, why we need to talk about adolescents and young adults, why it is different. Not only the population criteria, but also the demographic dividend of any country is driven by its young population. This is also the age where the risky behaviors often begins, substance abuse, unsafe sexual practices, and we also see the early onset of obesity, eating disorders, hypertension, and other non-communicable risk factors during this age, long before these issues become evident in adult life. If we are not intervening now, we are missing a critical window of prevention. So this is the data from the WHO. In spite of better health facilities in recent time, adolescents still face significant health challenges in terms of nutrition, infectious disease, and mental health. As you can see in this, the right side, in females, the top 5 causes of morbidity, in that iron deficiency, anemia, lower respiratory tract infections are most common in age group of 10 to 14, and 15 to 19, again the iron deficiency, anemia is the most common, followed by depressive disorders. In males, iron deficiency, anemia, road injuries is common in 10 to 14, and in 15 to 19, road injuries again, and interpersonal violence becomes the second most common. When we talk about the deaths, in females, again, infectious diseases, maternal conditions, again, comes in 15 to 19 age groups, and in males, road injuries, interpersonal violence, and mental disorders are the most common cause of deaths. So in today's topic, we will be discussing about the normal growth and development, lifestyle disorders, sexual and reproductive health, nutrition in adolescents and young adults, physical activity in adolescents and young adults. And in the next part, we'll discuss about the mental health conditions, psychosocial counseling and history taking in adolescents and young adults. So to continue with the presentation, I would like to invite Dr. Nipun Sharma, second year PG resident from Department of Family Medicine, to discuss about normal growth and development, lifestyle disorders in adults and young adults, adolescents.
Good morning, respected dignitaries, teachers, and my dear colleagues. I, Dr. Nipun, will be discussing about the normal growth and development in today's PGCR. Now, normal growth and development is divided into 3 domains, that is physical, cognitive, and psychosocial. As we discuss about the physical domain, adolescent faces significant increase in height and weight, which is characteristic feature of this phase. In girls, the growth spurt typically occurs between the age of 9.5 to 14.5, with the fastest growth is happening around the age of 11.5. In boys, the growth spurt is happening between the age of 10.5 to 16, with the most rapid growth occurring at the age of 13.5. During this period, boys typically gain around 7 to 30 kilograms of weight, and in girls, gain around 7 to 25 kilograms. Next, we discuss about the cognitive domain, expansion and establishment of the abstract thought process. That is, thinking becomes more philosophical and futuristic, covering a broader range of topics. Adolescents form their own ethical codes, that is, they begin to develop their own moral compass. They have long-term thinking, that is, they start to consider their future goals and their consequences. Questioning and analyzing develops in this phase. Next, we discuss about the psychosocial domain. Teenagers become preoccupied with the physical changes and their appearance. They develop their own identity. and their self-image is heavily influenced by how others are perceiving them. They begin to challenge their parents' authority and seek more independence and privacy. Peer groups become intensely important during this phase. Social expectations and pressures are the major influences. So let's see the physiology behind the growth of adolescence in terms of physical growth and brain development. In this diagram, we can see hypothalamus releases gonadotropin releasing hormone, which acts on the anterior pituitary, which in turn releases luteinizing hormone and follicle stimulating hormone, which acts on the testes to release testosterone and ovaries to release estrogen and progesterone. Now let's understand the reason behind the cognitive and psychosocial changes in the adolescent phase. As we can see, the limbic system, which develops in the early adulthood, predominates and is responsible for the pleasure response, social bonding, motivation, and memory formation. While in the mid to late 20s, that is in young adults, prefrontal cortex predominates, which helps in attention and focus, social behavior, working memory, and impulse control. Next, we discuss about the brain development. Prefrontal cortex, as we have seen, which developed in the late 20s, is responsible for decision making, impulse control, and planning, which leads to impulsivity and poor judgment. Limbic system, which develops in the early adolescent, responsible for emotions and rewards, which develops earlier and motivates the adolescent to take the risk. Synaptic pruning, responsible for better processing of information. It is in continuous development phase. Corpus callosum continues to thicken. Neurotransmitters like dopamine and serotonin have increased activity in the adolescent age. That's why adolescent seeks more pleasure-seeking activities and rewards, which releases serotonin and eases the tension. Now we'll talk about the general growth pattern in the adolescent phase. Boys have increased shoulder width, while in girls, due to hormonal effects, bones are more stronger and they have broader hip. Voice becomes deep to high tones in boys and become deeper and fuller in girls. Boys have lean body mass as compared to girls, which have chubby body mass. Muscles are well developed in boys, and muscular mass increase proportionately to general tissue growth in girls. Boys have more sweating as compared to girls. Extremity hairs are more, and sebaceous glands is more active in boys. Now let's discuss the normal pubertal changes in the girls. Breast change, that is thelar, is the earliest sign of puberty that appears in the girl around the age of 8 to 11 years. Rapid increase in height and weight occurs around the age of 10 to 13 years. Growth of pubic hair, that is pubar, occurs at the age of 9 to 12 years. Then appearance of axillary hair takes place. Menstruation, that is menarche, starts at the age of 11 to 14 years, which usually begins 2 years after the thelar. And there is abrupt deceleration of linear growth at the age of 16 to 17 years. Now let's discuss about the sexual maturity rating, that is Tanner staging in girls, which is divided into 5 stages on the basis of 2 criteria, that is breast development and pubic hair. In stage 1, which is prepubertal stage, no breast tissues are formed and pubic hair are same as the abdominal hair. Stage 2, breast bud appears and pubic hair becomes more sparse, which leads to stage 5, which is the final stage of development, and adult breast contour and pubic hair becomes of adult type, spreads to medial thigh as well. What are the pubertal changes in boys? Enlargement of testes is the earliest sign of puberty in boys, in volume of more than 4 ml and size of more than 2.5 cm, occurring at the age of around 9 to 12 years. Growth of pubic hair, upper lip and facial hair occurs at the age of 11 to 13 years. Change in larynx and voice at the age of 12 to 14 years. Rapid increase in height at 13 to 15 years. Nocturnal emission starts at 13 to 15 years, and there is abrupt deceleration of the linear growth at the age of 17 to 18 years. Tanner staging in boys is again divided into 5 stages, which on the basis of 3 criteria, that is genitalia, testicular volume, and pubic hair. Stage 1 is prepubertal stage, with testicular volume less than 4 ml and pubic hair are same as abdominal hair. Stage 2 is where the actual pubertal growth happens, in which early penile growth, thinning, and reddening of scrotal skin takes place. Testicular volume rises to 4 to 10 ml, which leads to stage 5, which is the final stage, in which genitalia becomes of adult size of testicular volume more than 20 ml. Now, what are the developmental parameters in different stages of adolescence? In early adolescence, that is between the age of 10 to 13 years, As we have seen the physical development, they have rapidly occurring changes, they have interest about sex organs, they become concrete thinkers in the early adolescent phase, lack of control on impulse actions, friends become more important than family in the early adolescent phase, and they have conceptual comprehension. While in middle adolescent, that is 14 to 17 years, abstract reasoning develops, they have increase in the risk-taking behaviors, they become more autonomous, friendship become more common with both the sexes, and high order thinking begins. In late adolescence, they have establishment of the abstract thinking, they have the reconcile the relationship with their parents, they have less conflict with the parents in the late adolescence as compared to early, they have competent relationships, and they are able to make realistic decisions. Now, what are the pubertal disorders? Now, parents come to your OPD and ask certain doubts about the development. That is, my son is 7 years old and he has started growing mustache. Is this normal? My son is 18 years old and has not grown the beard yet. My daughter is 16 years old but has not shown any changes of physical development. The first pubertal disorder is precocious or early puberty. It is defined as the start of pubertal signs, that is thylarch in girls and testicle enlargement in boys before the age of 8 and 9 respectively. There are two types, central and precocious. Central precocious puberty is gonadotrophin dependent, in which there is early activation of the hypothalamo-pituitary gonadal axis. It follows the normal sequence of puberty and causes are idiopathic, genetic and brain tumors. Peripheral precocious is gonadotrophin independent due to the excess sex steroids. It do not follow the normal pubertal sequence and causes are gonadal or adrenal or germ cell tumors or congenital adrenal hyperplasia. Delayed puberty, it is defined as the failure to start or progress to the puberty beyond the normal age limit. That is 13 in girls and 14 in boys. Causes include constitutional delay, which is the most common cause, hypogonadotrophic hypogonadism, that is low or absent gonadotrophin releasing hormone or LHFSH. Common causes are chronic illness, pituitary, hypothalamic disorders, and Kallmann syndrome. Hypergonadotrophic hypogonadism, in which gonadal failure is there. Examples are Turner's in girls and Klinefelter in boys. Now, how we will approach to the precocious puberty? Thorough history and examination should be done, which is suggestive of precocious or delayed puberty. Examination include height, weight, body mass index, growth charting, and tenor SMS staging. We should assess the chronological age by wrist or hand X-ray. Basic investigations like CPC, TSH, PET should be ordered, hormonal assay if required, and appropriate radiological investigations when indicated. Proper endocrinology referral should be taken, and we have to reassure the parents and regular monitoring to be done. What are the health implications in adolescence? As now we have seen the normal growth and development, we have seen adolescent goes through physical changes, that is increase in height and weight, which leads to increased nutritional requirement, can lead to undernutrition and anemia. Breast development can lead to stooping of shoulders, poor posture and back pain. Skin becomes oily, which can lead to acne. They have a desire to be thin and have a good figure, which can lead to malnutrition, anemia. They have a desire to have sexual intercourse, which can lead to unsafe sexual practices, which can lead to unwanted pregnancy and sexually transmitted infections. Menstruation can lead to dysmenorrhea, menorrhagia, anemia. They have going through the emotional changes and social development, which can lead to confusion, moodiness, and irritation. They are very curious, which can lead to risk-taking behavior. Peer pressure is an important aspect in this phase, which can have an effect on lifestyles, including unhealthy eating habits, smoking, and alcohol. Now, for the sake of the presentation, we have divided the adolescent health problems into 6 parts. We will be discussing about the lifestyle problems, reproductive problems, and nutritional problems in this aspect, and next will be discussed in the upcoming PGCR. Now, what are the lifestyle diseases in adolescents and young adults? Major problem in the lifestyle disorders are diabetes, hypertension, dyslipidemias, metabolic syndrome, and PCOS, which has dyslipidemia, which has 60% prevalence rate, and metabolic syndrome at 24%. Let's discuss about the risk factors and consequences of the lifestyle diseases. Unhealthy eating habits, physical inactivity, increased screen time, stress and inadequate sleep, parental obesity and family eating patterns, which can lead to obesity and diabetes, dyslipidemia, hypertension and cardiovascular diseases, obstructive sleep apnea, fatty liver disease, and low self-esteem. Now, adolescent obesity is a lifestyle-related issue which can lead to a variety of metabolic problems, and it is very crucial to recognize the obesity prior to the development of complications. Now, parents is coming to our OPD with a concern that is 15-year-old child weighing 70 kilograms and 150 centimeters. He was 60 kilograms a year ago. He tried dieting and all the other physical activities but didn't work and rather developed pain in his knees. Are there any pills or medicines to reduce his weight? Will he need the bariatric surgery ultimately? Now let's discuss about the diagnosis of obesity. Underweight is defined as the below the 5th percentile of the standard IAP chart. Healthy is defined between the 5th and 85th percentile. Overweight is at or above the 85th percentile, below the 95th, and obesity is ultimately defined above the 95th percentile of the standard IAP chart. Now, as we can see in this IAP boys extended BMI chart, our case has a BMI of 31.1, which is marked with the black asterisk mark, and it is falling in the class 1 obesity. The chart is for the girls, which is pink in color. Earlier, obesity was taken as a problem, but now obesity is a disease which have consequences on the multiple systems. Endocrine responses include impaired fasting glucose, metabolic syndrome, menstrual irregularities, delayed puberty or early puberty, and dyslipidemia. Physical responses can have impact on asthma, immobility, GERD, scoliosis. Psychological response can have isolation from peer group, bullying, anxiety, depression, and bulimia. Now, what is an approach to obesity? Screening and diagnosis. We have to assess the BMI percentile as we have discussed, appropriate for the age and gender. Initial evaluation include history and physical examination, focusing on the growth, development, pubertal status, and lifestyle and eating behavior. Evaluate for the comorbid conditions and other risk factors, chronic stress, and weight loss history. Management include first line intervention is lifestyle intervention, which should include comprehensive family-based behavioral therapy, diet and physical activity, and prevention and treatment of comorbidities. Endocrinologist referral to be taken if BMI is more than 30 kg, or pharmacotherapy will be started if BMI is more than 30 with comorbidities, and bariatric surgery is indicated if BMI is more than 40 or between 35 to 39 with comorbid conditions. Now let's discuss about the screening of the diabetes in the young population. Screen all young population of diabetes if any of the following factors are present, that is BMI is more than 25, there is personal history of cardiovascular disease, hypertension, dyslipidemia or PCOS, family history of diabetes, maternal history of the gestational diabetes, acanthosis nigricans, hypertension, dyslipidemia. Order one of the tests like fasting plasma glucose or HbA1c or oral glucose tolerance test. If patient will be falling in the pre-diabetic range if fasting plasma glucose is between the 100 to 125 or HbA1c is between 5.7 to 6.4 with OGTT of 140 to 199. Diabetic if fasting is more than 126, HbA1c is more than 6.5 and OGTT of more than 200. ADA, that is American Diabetic Association, recommends screening to be started at the age of 10 years or onset of puberty, whichever is earlier, and they have to be repeated every 3 years if these factors are present. Now parents is coming to the OPD and ask about the hypertension in their child and ask what is the need for evaluation. Does my child require evaluation for the high blood pressure and what are the causes of high BP in this age? Now, for the screening of hypertension, annual BP screening at routine health visits is recommended at all the healthcare clinics. Appropriate average of 2 or more readings should be taken on at least 2 separate occasions. For higher readings, we have to measure out of office measurements. For screening of hypertension, IAP recommends the standard centile charts, and for the adult, the guidelines are same as for the adolescent population. What are the causes of hypertension? As we can see in this diagram, the primary cause, that is essential hypertension, is forming the major chunk, that is 68%, and the secondary causes are forming the 32% of the causes, which includes primary aldosteronism, renovascular hypertension, pheochromocytoma. If the young adult is diagnosed with the young onset hypertension, we have to order the proper investigations, including creat, thyroid, ECG, and echo. Secondary causes to be ruled out, and additional imaging, if required, should be done. Lifestyle changes are the first line of treatment, including weight loss, diet, and exercise. We have to assess the cardiovascular risk, and if BP is more than 140/90, pharmacotherapy to be started. Drug of choices are ACE inhibitors and ARBs. Metabolic syndrome, which is again the very common problem in the adolescents. It is a cluster of conditions including central obesity, high blood pressure, high triglycerides, low HDL, and high blood sugar. As per the IDF diagnostic criteria, waist circumference is more than 90 centimeter in men and more than 85 in women is the mandatory criteria, plus any two of the following, that is fasting triglycerides of more than 150, HDL less than 40, blood pressure of more than 130 at 85, and fasting plasma glucose of more than 100 is required. Now we will discuss what will the prevention of the lifestyle diseases. Intake, 3 meals a day should be recommended. Diet as per the age requirements. 2 to 3 servings of the dairy and fruits. No fast food. Avoid sugar and carbohydrate rich foods and praise for the healthy dietary habits. Moderate to vigorous activity for 60 minutes per day is recommended. Screen time to be reduced to less than 1 to 2 hours. Routine sleep time. No TV in the bedroom. Parents to not to be over controlling. Minimize the obesity causing drugs like antipsychotics, steroids, and certain antiepileptics. Now we'd like to call Dr. Kajol from the Department of Obst Gynae to discuss about the sexual and reproductive health.
Thank you, Dr. Nipun. Good morning, respected teachers, colleagues, and juniors. Today, I am going to present on topic sexual and reproductive health in adolescent and young girls. Now, many parents of young girls approach with concerns about their teenager daughter with problems of menstrual irregularities, unsafe sexual behavior, and unwanted pregnancy. So, I will be discussing these topics in today's session. Like here, the mother wants counseling for her 16-year-old daughter about menstrual hygiene, safe sexual behavior, and relationship. Establishing healthy menstrual habits early is crucial for long-term reproductive and overall health. So we have to aware young girls about normal pattern of menstrual cycle. The normal length is 21 to 35 days for duration of 2 to 7 days with blood flow ranges between 30 to 80 ml. Many parents are worried about their teenager daughters who started menstruating and having irregular menstrual cycles. So we have to educate them that it is normal to have irregular cycles, as hypothalamic pituitary ovarian axis takes 2 to 3 years for maturation after menarche. But any deviation from normal pattern after that requires evaluation. The second important aspect is tracking menstrual cycles. We should encourage them to track their menstrual cycle by using calendar, and they should record the start and end dates of cycle, blood flow characteristics, and any associated symptoms. Young girl needs adequate iron-rich balanced diet to prevent anemia due to blood loss during menstrual cycle every month. Next, for menstrual pain and discomfort, we can give NSAIDs, advise them for hot fermentation, and encouraging them to do regular physical activity. Now the mother usually are the first source of information about menstruation, and we should also provide accurate age appropriate information and to create a comfortable environment where adolescent and young girls feel safe to discuss their menstrual concerns. Now let's talk about the hygiene practices during healthy hygiene practices during menstruation. Poor menstrual hygiene can lead to problems like genital infection, school absenteeism, and reduced quality of life. Sterile sanitary pads and napkins are the best primary option we can recommend to them, and the pads should change every 4 to 6 hours to prevent infection. Second is the genital hygiene. Girls should wash the genital area with clean water and to avoid vaginal washes, since this can cause irritation and disturb pH balance. And also it is important to follow front to back wiping methods after urination or defecation to prevent infection. Safe sexual practices can be well studied under three broad headings comprising their prevention, implementation, and the challenges faced. Inconsistent use of safe sexual practices can lead to STIs, HIV, or HPV infection. So the first step is the use of barrier methods of contraception like condoms. These not only give protection against STIs but also reduces risk of skin and mucosal contact disease. The HPV vaccination is recommended to all adolescents, and it is also included in the new part of a new immunization schedule. It is recommended for age group of 9 to 26 years. Screening plays a key role for young women who are sexually active should be regularly screened for genital infection and should have pap smear every 3 years. Implementation of safe sexual practices in adolescents require both healthcare support and effective communication. Schools can be a powerful platform to run educational programs on safe practices. At the same time, healthcare providers play a crucial role by encouraging them to use for consistent and correct use of barrier methods of contraception. Challenges faced in promoting safe practices. Firstly, improper and inconsistent use of contraception, failing to screen asymptomatic patients, and thirdly, incomplete partner management often causes reinfection. So, effective prevention and implementation requires to address these gaps. The Government of India has launched a program for adolescents which focuses on empowering adolescents for safe sexual and reproductive health by reaching them through school, families, and communities. It focuses on education about safe sexual practices, contraceptive choices, menstrual hygiene, and prevention of STIs and HIV. Support is provided through counseling, access to sanitary products, iron supplements, and life skill training such as decision making, negotiation, and self confidence. Teenage pregnancy often results from unsafe sexual practices and improper contraceptive use. The risk factors are lack of awareness of safe sexual practices and contraception, early marriage, lack of social support, which leads to unwanted pregnancy, STD, HIV infection. HPV infection leads to early cervical cancer and prevented by sexual awareness and use of correct contraceptive methods. This chart shows the WHO tiered approach to contraceptive effectiveness. The most effective are long-acting reversible methods like subdermal implants and hormonal and copper intrauterine devices, with less than one pregnancy per 100 women per year. The next are injectable contraception, oral pills, contraceptive patch, and vaginal rings, which are effective but depend on regular use. Barrier methods like condoms as well as fertility awareness methods are less effective and user dependent, but barrier methods provide protection against STIs. And lastly, the least effective are withdrawal methods and spermicides with highest failure rates. Now coming to a scenario where mother came in OPD with her daughter with complaint of that my 14-year-old daughter has a lot of abdominal and back pain, especially during first 2 days of her periods. Should I give her any medicine or is it normal? So here the girl came with the complaint of dysmenorrhea, which is a cramping pain that accompanies during menstruation, and it can be primary or secondary. The primary dysmenorrhea usually begins since menarche, and the symptoms include cramping pain with nausea, vomiting, and this is due to excessive uterine contractions and prostaglandin release. And should be treated with reassurance, hot fomentation, and NSAIDs for pain relief. The secondary dysmenorrhea appears later, usually after 20 years, with pain beginning a few days before menses, associated with dull leg pain, dyspareunia, and the common causes include endometriosis, PID, adenomyosis, and fibroids. And the treatment is to address the underlying cause. Now coming to a second scenario where mother came in a OPD for advice for her 14-year-old daughter having ongoing bleeding for 8 to 9 days, and she fully uses up 8 pads. The suggestive diagnosis for this complaint is heavy menstrual bleeding, which is defined as menstrual blood flow either excessive more than 80 ml or for more than 7 days. And the most common cause in adolescent girl for heavy menstrual bleeding is anovulatory cycles, and other causes are endocrinal, which includes PCOS, hypo or hyperthyroidism, hematological causes, pelvic tumors, and pregnancy complications like abortion. Clinically, the girl will complain of heavy menstrual bleeding or flow with passage of clots and with increased usage of sanitary pads and generalized weakness. NSAIDs and antifibrinolytics can be given to stop the bleeding, and iron supplementation is also given to compensate the blood loss or anemia. In refractory cases where bleeding does not stop by antifibrinolytics, we can give cyclic progestogens, and rest is to treat the underlying cause. Jumping to the final scenario where a mother came with her daughter, 18-year-old daughter complains about her menstrual cycle that have been delayed coming for 2 to 3 months, and she developed acne and facial hair. What would be the causes? Causes of delayed menstrual cycle can be, first of all, we have to rule out pregnancy, PCOS, functional hypothalamic disorders, hyperprolactinemia, hypothyroidism, and primary ovarian insufficiency. Most likely differential diagnosis based on the history of girl is polycystic ovarian syndrome, which is most common endocrine disorder in adolescent and young girls. It is multifactorial and polygenic condition. In India, its prevalence among adolescent girls ranges from about 12 to 24%, and more than half of them are obese. The pathophysiology includes insulin-resistant chronic anovulatory cycles and hyperandrogenism. The risk factors of PCOS are obesity, sedentary lifestyle, genetics, and unhealthy diet. Now, the diagnosis of PCOS is confirmed by the widely accepted Rotterdam criteria, which comprises of menstrual changes, hyperandrogenism, and polycystic morphology on USG. At least 2 out of 3 criteria must be present for diagnosis. Other tests like serum thyroid, prolactin, and other hormone profile can be done. By treatment, we will advise them for the lifestyle modification, and the symptomatic treatment can be given like insulin sensitizers and OCPs for cycle regulation and hirsutism, and psychological support. Long-term complications are type 2 diabetes mellitus, cardiovascular disease, endometrial and breast cancer. Pregnancy-related complications are infertility, early pregnancy loss, diabetes, gestational diabetes, and preeclampsia. Now I would like to invite Dr. Ritik from Department of Clinical Nutrition to discuss on nutrition in adolescent and young adults.
Good morning, respected dignitaries and audience members. So far in the session, we've seen about mental and physiological changes in adolescents and their health problems. Now let's take a look at the nutritional concerns and its management. So why are we talking about this? It's because of the scale and prevalence of malnutrition in this age group. As you can see in the stats from CNS, the prevalence of undernutrition, anemia is at 29%, and vitamin D insufficiency is at 60%. For overnutrition, pre-diabetes is a major concern. So this is the current scenario. Now, why is nutrition important in adolescents? It's because the requirements are significantly high due to rapid growth and development in the body. And there's also sexual maturation and brain development that is taking place. Besides, there are some risk factors during adolescence: nutritional illiteracy, hormonal changes, binge eating, sedentary lifestyle, to name a few. And as a consequence of these factors, there's undernutrition and overnutrition. Now, an anxious mother comes with a concern asking for balanced diet for her adolescent. So, what do we suggest as a nutritionist or a dietitian? This is a healthy plate given by NIN for a 2000 calorie per day diet. Half of the plate should be filled with fruits and vegetables. 2/3 of the remaining half should be filled with cereals, and the remaining 1/3 should be filled with pulses and your healthy fats or nuts. And now, how much should an adolescent eat to fulfill their RDAs? So, to fulfill the requirements for 10 to 12-year age group, they need to consume about 9 servings of cereals, 3 bowls of lentils, 100 grams of fresh vegetables, 3 bowls of cooked vegetables, 1 serving of fruit, a handful of nuts, 2 tablespoons of oils, and 2 glasses, which is about 400 ml of milk. The requirements will slightly increase in 13 to 15-year age group. Eating together on the table without any screens, ensuring proper nutrition so that best outcome is achieved for the entire family. Parents can be good role models for their children. Taking a balanced diet, ensuring variety in your diet is really important. Involving adolescents in preparation of meals, and then eating minimum 3 meals and 2 to 3 snacks per day, not skipping any meals, especially your breakfast. We discussed about the healthy population. Now coming to the problem of malnutrition, how do we address that? So first comes nutritional assessment. The standard criteria that we follow is ABCD criteria, where A stands for anthropometric. This includes your BMI, lean body mass, fat mass, etc. B is biochemical investigations, which is your CBC, KFT, serum electrolytes, lipid profile. C is clinical. So we assess the individual for clinical signs and symptoms of nutrient deficiencies. And D is dietary assessment. The common retrospective method we use in practice is 24-hour dietary recall. Looking at the Z scores, growth scores, if an individual is below -2 SD, it is classified as undernutrition, and over 2 SD is overweight or overnutrition. Some goals in overnutrition management. So our first goal is restoring healthy growth velocity in the adolescent, then correcting the deficiencies, improving functional outcomes, and addressing cause to prevent the relapse. Nutritional rehabilitation in undernutrition. So for general rehabilitation, we provide the individual with about 50 to 70 kilocalories per kg body weight per day, and protein is given at 1.2 to 1.5 gram per kg body weight per day. In patients with high refeeding risk, we have to start slow with about 10 to 20 kilocalories per kg per day, and then progressively increase. Thiamine is given often, and electrolytes have to be monitored closely. Some practical guidance tips. Energy-dense whole foods are recommended. Taking small, frequent meals. Supplementation if required, and weekly iron folate supplements. Screening for micronutrient deficiencies and deworming as per local schedule. For monitoring and targets, reviewing every 1 to 2 weeks until steady catch-up, and then monthly reviews. We aim for about 1 to 2% body weight gain per week in moderate cases. And like I already said, monitoring electrolytes for the first 72 hours of refeeding. Another concern from a parent for their adolescent. The 15-year-old weighs 70 kg. He was 60 a year ago, always low in energy and developed pain in knees. Has borderline sugars and fats, and also pre-hypertensive. So the patient is diagnosed as obese and is at risk of metabolic syndrome. For management goals, we have to improve cardiometabolic abnormalities, preserve normal growth and development, treat comorbidities, and we aim for 5 to 10% reduction in body weight. Now, management of metabolic syndrome. We advise adding complex carbs, fiber, and protein to the diet, which means your whole grains, especially millets, lentils, plenty of fruits and vegetables, like we already saw in the healthy plate by Anand, and rotating your oils. So no one particular oil is recommended. We advise to rotate your oils, maybe on a 15-day basis or a monthly basis. Then some lifestyle modification tips: eating frequently in small portions, eating in a caloric deficit, if you eat in a deficit of 3,500 kilocalories, that you lose about 1 kg. So if you are in a deficit of 500 kilocalories per day, in a week you lose 1 kg. Then physical activity, that we'll further talk about. What to avoid? So cutting down on refined carbs, sugars, ultra high processed foods, salty snacks and trans fats from your baked products and street fried items. Now there are some government schemes to tackle and combat the issue of malnutrition in our country. So for its prevention and control, we have Poshan Abhiyan by Ministry of Women and Child Development, the flagship program for life cycle nutrition mission to reduce stunting, underweight, anemia, low birth weight, convergence and community mobilization. Then we have ICDS, targeting adolescent girls. The features are Anganwadi-based package for supplementary nutrition education and growth monitoring. Anemia Mukt Bharat is really important to tackle anemia in adolescents and other vulnerable groups. So follows the 666 strategy, where there are 6 target groups, 6 interventions and 6 mechanisms. Weekly iron folic acid tablets are given, which provide 100 milligrams of elemental iron, 500 micrograms of folic acid under NIPI, National Initiative plus National Iron Plus Initiative. And then we have National Health Mission by Ministry of Health and Family Welfare, targeting RMNCH plus A groups, which is reproductive, maternal, newborn children and adolescents, and focuses on health and nutrition services, including immunization, growth monitoring, and counseling. So, for discussing about physical activities, I would like to invite Dr. Heena Jain.
Good morning, dignitaries, teachers, and my dear colleagues. I'll be discussing about physical activity in adolescents and young adults. Okay, before moving further, there are some concerns. Lately, he has been gaining weight. Now she wants him to spend some time outside for physical activity. So she asked me to guide me with some exercises that he can do. Now, across the world, adolescents are becoming increasingly inactive due to study stress, lifestyle changes, and technology use. More than 80% of young aged 11 to 17 globally do not meet the WHO's recommendation of at least 1 hour of daily physical activity. Prevalence of physical inactivity is higher in girls than boys, and 74 to 77% of Indian adolescents are physically inactive. Recommendations for daily physical activity. First is aerobic activity that should be performed for 60 minutes or more of moderate to vigorous intensity exercises with vigorous activity on at least 3 days a week. For example, running, swimming, cycling. Muscle strengthening exercises includes climbing, resistance exercises at least 3 days a week, and bone strengthening exercises such as running, jumping, sports, and weight-bearing exercises at least 3 days a week. Risk of inactivity, postural problems and back pain, adolescent idiopathic scoliosis, lifestyle diseases, mental health and body image concern. Now, ergonomic is equally important for growing adolescents and young adults. So, ergonomic advice is given to them, that is, set up ergonomic study spaces with supportive chairs that allow feet to rest, flat on the floor, and desk setup where elbows are at 90-degree angle. Position the computer at eye level about an arm's length away to prevent head and neck strain. Ensure students use both back pain straps and keep the body weight balanced. Posture should be correct by using correct posture techniques, that is, take frequent breaks, that is 2 minutes every 20 minutes during sedentary activities like screen used to move and stretch, and while lifting heavy objects, bend the knees and lift with the legs, not the back. Now, there are some exercises that adolescents and young adults should inculcate in their daily life. First, to activate your core and stretch your hips, that is posterior pelvic tilt, segmental breathing, single knee to chest exercise, lower trunk rotation, figure 4 stretch. Exercise to improve spinal mobility and posture correction, that is thoracic extension exercises, scapular retraction, lunges with reach, cat-cow, and open book. Now, obesity is the major concern in young adults. So, specific management for obesity, that is at least 150 minutes of moderate to vigorous aerobic exercises and 2 days of strengthening training. Recommendation and best practices, that is tailored intervention for adolescents, family, school and community involvement, integrating physical and psychosocial health, preventive and early approach. Thank you. Now I would like to call Dr. Shalini ma'am.
Before going to take home message, I would just like to highlight a few important points. Why what barriers we have in terms of adolescent health, why we are not able to take care of them, or maybe just lagging behind. They have a fear of judgment. They fear the lack of privacy and the confidentiality issues are there. And also we have limited youth-friendly services across the globe or countries like India, developing countries like India. So I would just like to wrap up this with saying that adolescent health is not a nick pill. It is foundational to work as doctors. Early intervention during this stage leads to healthier, more resilient adults. As future physicians, you have the power and responsibility to make lasting differences. Adolescent medicine or adolescent health is not unique to one specialty, it is unique to all. We have to build trust and ensure confidentiality in them. Prevent, don't just treat. Thank you. And the next part will be dealing with the mental health, psychosocial counseling and history taking in adolescents and young adults, which will be on 7th November.